Building Block 8, Prompt Access to Care, Understanding Common Metrics and Approaches to Improve Access. Access refers to being able to get the right care in the right way at the right time. In the context of the clinical practice, one prominent component of access is the ability to get care from the clinical team, often through an in-person appointment when needed. Access is a major driver of patient experience, so it is a high priority for many practices seeking to improve patient experience. The consequences of poor access are sobering. A principal cause of emergency department use is a lack of access to primary care. People with no usual source of care, especially those with low incomes, are more likely than others to visit an emergency department. In communities with poor access to primary care, the population has higher death and disease rates and greater health disparities than in communities where access to primary care is better. Communities with worse primary care access have higher rates of emergency visits and hospitalizations as a result. Good access to in-person appointments means balancing supply and demand of visits. First, let's discuss how to measure supply and demand. Supply of in-person visits for one clinician for a year is calculated as the number of days the clinician works per year times the number of patients they see each day. So if a clinician works 135 days per year and sees 20 patients per day, their supply of appointments would be 2,700. Demand is often calculated as the number of patients in a panel times the average number of visits per year. If there are 1,800 patients on a clinician's panel and they average 1.5 visits per year, the anticipated demand is 2,700. Note that this is an imperfect measure because if a practice has access problems, the average number of visits may be artificially low. In this case, our supply and demand are balanced. In many cases, demand may exceed supply. When demand and supply of visits are not balanced, there are a number of strategies that we may consider. To reduce demand, we may reduce the panel size of a clinician or provide alternatives to one-on-one in-person visits. One common way to reduce panel size is to close panels to new patients, during which time the practice is not accepting new patients. The clinic panel size should gradually decrease as patients move or change practices. A team-based care approach that empowers front desk, medical assistant, and nursing staff through standing orders can help address routine patient questions, concerns, and care needs. Offering alternatives to in-person visits may also reduce the demand for visits. For example, some needs may be met through a patient portal, telephone calls, or group visits. All of these strategies open appointment slots for people who actually need to be seen in person and one-on-one. Fee-for-service payment models sometimes place constraints on a practice's ability to explore alternatives to in-person visits, but there are increasing opportunities through capitated models. Some surges in demand are predictable and may be more efficiently handled through alternatives to the standard medical visit. For example, school physicals and fall flu shots could be scheduled on special days with a streamlined workflow. Freezing a select number of appointments until a day or two ahead can help ensure that at least some appointments are available for urgent visits. One final note. It is also worth considering why appointments are being made. When patients frequently present just for refills or for follow-up, it may be an indication that follow-up visits are being scheduled more often than necessary. Unnecessary visits may be reduced by longer prescription renewals for routine medications and by scheduling check-in phone calls rather than visits. Front office staff could schedule phone calls to see if patients need follow-up visits and schedule those visits only if they are not doing well. To increase supply of visits, one may increase the total number of visits, reduce the no-show rate, or add capacity through other members of the care team. Increasing the number of visits available could be achieved by creating and implementing standing orders, empowering non-clinician staff to share the care, hiring additional people, and increasing the work hours of existing clinicians. Some practices also explore increasing the number of visit slots per half day, though this is likely to increase burnout and have negative long-term impacts on access. For many practices, reducing the no-show rate is low-hanging fruit that can improve access. The farther in advance an appointment is made, the more likely the patient will not show up to the appointment. Some practices do not open scheduling templates until 2 to 3 weeks in advance, which reduces the no-show rate. The disadvantage is that some patients prefer to schedule far in advance. If demand outstrips supply of appointments, this model may not increase access. Other strategies to reduce no-show rates are to provide reminder emails, text messages, or calls, and to offer an easy way to cancel appointments, such as text option or a dedicated line for cancellations. In order for these newly reopened appointments not to go to waste, however, a practice also has to be able to offer them in a timely way to patients who need them and to integrate the waitlist for patients desiring earlier appointments. For practices wishing to improve access, it is important to empower staff to act as flow masters, experts in how to fit in the maximum number of patients possible as the day evolves. Staff should feel confident that they can fill appointment times as they open or even shuffle appointments as people arrive early or late to work in additional patients when possible. As one physician told us, "I am the expert in medical care, but my MA is the expert in clinic flow. I tell her I want to see 11 patients this afternoon. She makes the decisions about how to work people in." Finally, other team members could add significant capacity to a practice. For example, research shows that nurses or pharmacists may be as effective as a physician in titrating blood pressure medications until patients reach their goal. Physical therapists may act as effective care for patients with uncomplicated low back, knee, or shoulder pain. By integrating the resources available in their medical neighborhood, primary care providers can more effectively balance their practice's capacity and demand. For small practices without extended staff, medical assistants can also increase capacity. One community clinic trained a medical assistant to follow patients on anticoagulation therapy. She scheduled patients to have their INR monitored regularly using point-of-care testing and could immediately seek clinician support to adjust medications if results were out of range. Another emerging model of care, popularized by Bellin Health, increases clinic capacity by assigning 2 medical assistants to each clinician. Medical assistants meet with the patient before the visit to review their preventive care needs, their reasons for the visit, and their medications. They stay in the room during the visit to document the visits in the electronic health record. Then they stay after the clinician leaves to ensure that the patient can describe the care plan in their own words and to make any needed follow-up arrangements. Because physicians no longer spend time on EHR documentation, they have time to see more patients in each half day, thus increasing the supply of visits while covering the cost of additional staff. In a smaller practice, medical assistants may be able to meet with patients before and after the care visit, while providers may be able to leverage existing scribing technologies to help take notes during the visit itself. Access should be measured at both the level of the clinician and when there are multiple clinicians working together at the level of the practice. There are several common ways to measure how good access to care is for patients. Access is measured through metrics such as the third next available appointment, percentage of same-day appointments, or percentage open capacity. To calculate the third next available appointment, we count the number of calendar days until one reaches the third open available appointment slot. The reason we look for the third next available rather than the first is that it's more a reliable indicator of schedule openings, because the first or second slots are often due to last-minute cancellations rather than general availability. It is also important to note that many people don't have the flexibility to take advantage of same-day appointments due to work, caregiving, etc. The third next available appointment is therefore more representative of meaningful access to the consumer. While there are no hard rules, a third next available appointment of 2 days or less is a goal worth aiming for, though hard to achieve. The percentage of same or next day appointments refers to the percentage of slots available to be filled on the day of the visit or one day before. It is calculated as the number of appointments scheduled today over the total number of appointment slots for the day. For example, let's say 2 appointments on the afternoon schedule were filled today and 1 yesterday, out of a total of 6 appointment slots. So the provider has 50% same or next day appointments. The percentage open capacity is the number of open appointment slots out of the appointment slots available. Usually, it is calculated for a period of time in the near future, often 2 to 4 weeks ahead. For example, let's say there are 12 appointments available in the next 2 weeks out of 100 appointment slots for 12% open capacity. If we look at 4-week open capacity, there are 82 appointments available out of 200 appointment slots for 41% open capacity. However it is measured, the ability to get timely care is at the heart of patient experience. By measuring and tracking access and adjusting the levers of supply and demand, we can improve the care that we provide to our patients.